Our first presenter, Dr. Monica Ashraf, Assistant Lecturer of Pediatric Cairo University.
Good afternoon. Dear chairpersons and dear professors, good afternoon. I'll try to be as quick as possible. My presentation today is about a female patient. She's the second child of a consanguineous marriage. She presented to us at the age of 9 months with pallor, jaundice, and dark urine of acute onset. Her initial labs showed severe anemia with hemoglobin 4.3 grams per deciliter. Her MCV was 125 with normal TLC and platelet count, reticulocytosis, and indirect hyperbilirubinemia. The patient was decompensated and was indicated for urgent blood transfusion, but unfortunately, frequent mismatch occurred. Her diet Coombs test was positive, and the patient was labeled as autoimmune hemolytic anemia. She received high dose of methylprednisolone on 30 mg per kg per day and the least mismatched blood. But during the next few days and during the gradual withdrawal of steroids, the patient was not controlled and needed blood transfusion twice. So IVIG was given at a dose of 1 gram per kg per day for 2 days, and continued withdrawal of steroids was continued. And the patient was discharged on oral steroids on 2 mg per kg per day. And despite the oral steroid treatment, the patient still needed blood transfusion every 2 to 3 weeks. And all trials of withdrawal failed. Any trial to withdraw was precipitated acute attack of hemolysis. And after 6 months of treatment, we have to evaluate our treatment. The patient was on steroids, but developed severe side effects. In the first, she was cushingoid, she was hypertensive, and yet it was a poor response. The patient still needed blood transfusion every 2 to 3 weeks. And so we needed a steroid-sparing agent. Azathioprine was started at a dose of 4 mg per kg per day, and then cyclosporin was added 1 month later. But still no response was observed regarding her transfusion needs. Then elevation of liver enzymes occurred, and azathioprine was discontinued after 3 months, and still she was on cyclosporin and steroids. Meanwhile, the patient started to be admitted repeatedly with chest infection, gastroenteritis, and she developed recurrent skin abscesses. Her labs at that time showed leukopenia and absolute lymphopenia. Further investigations revealed low immunoglobulins, and her CDs. She was diagnosed as severe combined immunodeficiency. At that time, we thought of a trial of rituximab, monoclonal antibodies, anti-CD20, at a dose of 375 mg per square meter. But severe anaphylactic reaction occurred with cyanosis with the beginning of the first infusion of the first dose, and so it was discontinued immediately and was not tried again. And so the patient was on IVIG on 1 gram per kg every 4 weeks, partly as she was a SCID patient and to control the hemolysis, together with oral prednisone on 1.5 mg per kg per day. Luckily, there was partial improvement in her transfusion pattern. She was 3 months of transfusion. But still, all trials to decrease the steroid dose caused severe attack of acute hemolysis with drop of hemoglobin and need for blood transfusion. And this is a small graph of all the treatments she received over her history, starting from the age of 9 months till now. She's been on steroids all that time. She received azathioprine after 6 months of the initiation of the treatment for 3 months and was stopped to elevation in the liver enzymes. She's been on cyclosporin for 1 year and was interrupted as she was not responsive. The trial of rituximab was around that time of starting of the azathioprine and cyclosporin, and she's been on monthly IVIG for 1 year now. Our patient now is 2 years and 3 months old. She's cushingoid, she's stunted growth, she has delayed motor and mental milestones, she can't stand, she can say only 1 or 2 words. She's hypotonic and severely iron overloaded. With her last ferritin was 19,000. She's on steroids on 1.5 mg per kg every other day, and this regimen was started just 2 weeks ago. on Deferzirax on 30 milligram per kg per day. She's on IV IG 1 gram per kg, and now we had to shorten the duration between the doses to 3 weeks. So every 3 weeks, she's on folic acid and paracetam for her neurological affection. This triad of SCID, of delayed onset and autoimmune hemolytic anemia and delayed milestone, is it a coincidence or a PMP deficiency? The purine nucleoside phosphorylase deficiency is an autosomal recessive disease. It represents 4% of the SCID cases. It's an enzyme included in purine salvage pathway, and its deficiency leads to intracellular accumulation of deoxyguanosine triphosphate, which is toxic to lymphocytes. It can present in early infancy or it can present late. It's characterized by recurrent serious infections, early onset of neurological abnormalities in 2/3 of the cases, including spasticity, developmental delay, and mental retardation. It can also have failure to thrive and autoimmune disorders in 1/3 of the cases, and which will be the first presentation as in our patient. The patients, they have lymphopenia with low T cell count. The B cell and immunoglobulins may be normal or elevated. The natural killer cells count are valuable. The only definitive treatment is hematopoietic stem cell transplantation. So, I have a question. What is the possible next step for our patient? Is it a bone marrow transplantation? There is no fully matched donor. We've thought of Celsat or mycophenolate mofetil, but unfortunately the tablets can be crushed and she's too small to receive the dose in the full tablet. We were thinking of cyclophosphamide. It was mentioned in some literatures. Should we give another trial of rituximab after the severe reaction that happened? We're still in that maze. We cannot still decide what's the next step. I hope if anybody has any suggestion for our patient to help us, because as you can see, we are clueless. Thank you.
Thank you.
I think the curable thing is transplant should do for a transplant to match the donor.
Haploidentical?
Yeah.
We were thinking about the haploidentical, but what I saw in the literature is one case report with a patient of autoimmune hemolytic anemia and SCID. She did a haploidentical bone marrow transplantation, but she died shortly. She was 11 months old, and she died shortly after the transplantation. I'm not sure if it's. I'm not sure if we can try it again, or should we try another immunosuppressor?
One second generation anti-CD20 instead of rituximab with the less side effects.